All right, is it reportable?
Yes.
Yes, it's reportable, okay? What do we think should be in the care plan already? Okay, well, there's going to be information there about the mismanagement of money, right? Because he's panhandling. And it's the safety in the community because he was mugged and panhandling. We would want to make sure that that vulnerability for 3 was very specific about panhandling, okay? We would want to have information in there about how they can't navigate in the community. We'd want to make it very clear that they're safe as far as they can get from point A to point B in the community, but when they're out in the community, they're engaging in some risky behavior that we want to talk about, okay? What are some changes we think we want to make sure are in that care plan? What would we think about? Well, we want to check and make sure this is in here.
There's one vulnerability that talks about being taken advantage of by others, and that one should be in there.
Do we think number 1, 2, 3, 4, 5 is taking advantage of others or is being taken advantage of?
Oh, I was talking about
Of the other resident?
the other resident.
Okay.
Yeah, needs that.
Just think about, definitely, you'd want to think about it. One of the things I would think about for this is, are we doing anything about his addiction with caffeine and his smoking? So would we want to add NRT use, that we would be encouraging some of that? If he's out there panhandling because he's smoking and drinking a ton of coffee because he doesn't have the money to afford those habits, we would want to do some care planning surrounding that, correct? Hopefully we think of that, okay? Maybe we'd look at budgeting to help ration his coffee. Maybe we'd want to think about a payee, okay? All right, let's shift it around a little bit. I'm running a little bit out of time. I didn't know this was going to be so fun. The internal investigation is what we would do next. So based on what we did, we have to make the report. So what action do we take to protect resident 1 and resident 2? You want to just throw some out there? What we did? What we might do? Right, we're going to intervene immediately. We might restrict them from the commons. We might have one of them evaluated at APS. And we're going to provide a nursing assessment to make sure that there aren't any injuries. Okay, that's what we're going to describe in our internal investigation of what we did to protect the residents. Okay? What elements of the care plan were followed or not followed and what was modified. We talked a little bit last year about those goal progress notes and how at times we want to be using those to make sure we're making it clear why or why not we're changing a care plan, in particular when we're looking at something that might have to do with an incident report or an actual vulnerable adult report. So examples we might have offered, we want to include offered PRN medication and under what circumstances we would offer that PRN medication. Maybe talk to the psychiatrist, discuss budget agreement, options and benefits of that. And then what would we maybe modify? Maybe we'd want to change the care plan to include regular education with number 1 regarding lending money. We'll offer PRN or consider precaution checks when exhibiting mood lability or ruminating regarding other residents. Perhaps we'd put that for resident number 1. If that wasn't in there. Okay? What elements of the policy or procedure were followed or not followed? In front of you, you have the resident aggressive behavior policy. It's blue. And you can take a quick look at that. We won't go over it too much. But in there, it does explain some of the things that we can do when these incidents happen. And we don't often think to whip out our policy. I mean, I sometimes do. But I think that it's something that is a resource for people when we're thinking about what should we be doing or what can we do in certain situations. And there's some things in there that we need to do. So that's something you'll want to take a look at. And those are some of the basic things we already know that we do. One of the things I think we need to make sure that is happening, and I'm sure they are, I'm not present for them, are that we're having those team meetings. So when these things happen, we're getting together and we're talking about what can we do, what should we do, and what do we want to do going forward. And then we have to also articulate what action was taken to prevent reoccurrence to the resident or other residents as part of our internal investigation. So that we don't end up on Action News 4, great photo. I want to talk just a quick second about documentation. And this is really a little bit about defensive documentation and just making sure we're documenting in a person-centered care way. So we have a resident who wants to go out. It's terrible outside. It's not terrible anymore, which is really funny because at the time when I wrote this, it was terrible outside. resident wants to go out, it's really terrible weather, we don't think it's a good idea, so we are not going to write, resident is going out despite concerns related to weather. Writer explains she could freeze to death in these temperatures, however she ignored writer and is leaving. It's a little catastrophizing and it doesn't really look good in the record, right? But there are a lot of other things that we're going to want to include when we are documenting situations that we think are risky, right? That we think a resident is making a decision that we aren't very comfortable with, okay? So we're going to describe how the resident is dressed, right? That would be something we would want to include. Describe why they want to leave. Include how we have explained the risks. Include the resident's response and rationale for their decision. Include the benefit the resident is describing. No, I have to go out. When I go out, I feel better. It's important to me that I'm able to go out. What are we doing to mitigate the risk, right? Explain your rationale for providing the bus. Oh, I have a typo. The bus pass, which normally I do BUSS for the pass. You all do too, I've seen it. Okay, bus pass, packaging the meds, etc. And then who do we communicate this plan to, right? Who have we talked to? Have we confirmed that, hey, they want to go to Aunt Susie's? Did we confirm with Aunt Susie that she's home? Right? We might want to do that. Make sure she's home. Like, hey, will you let us know when she gets there so we know she gets there safe? Maybe review with the resident. Hey, when you get there and if something happens on your way back, you know the number to call, right? What's our number? So we want to document that we've done some of these things to make sure we're mitigating the risk that is part of that, right? And we can do that in an adversarial way, in a non-adversarial way. I gotta be done. Okay, I think I am done. Except for I gotta talk quickly, because it's a Rule 36 requirement that we talk about the Facility Assessment and Vulnerable Adult Agency Abuse Prevention Plan. It's on your table, it's white, and it's a big packet, okay? And in that, we talk about our assessment of the neighborhood, the facility, and the resident population, okay? And in that, we also talk about what measures we take to reduce risk, okay? I was gonna make you guess some of them, but it's on the table. So I'm going to give you pictures, and I want you to tell me what you think I'm communicating here. Shout it out. I'm out of time.
Aerial cords.
Pull cords. Report, right? That we're communicating. Communication is key, right? Communicating across shifts about what we're doing. Right, Pete, you got one?
Staff available 24 hours a day.
Staff available 24 hours a day.
In-services.
Cameras.
Trained staff, that our staff are trained to deal with the things that we have going on here. Who said something? In services, yeah. Okay. Our windows, do they open wide? No, they only open 8 inches. Okay. Safety precaution. And our fences, we have security fences. Well, we have fences that we say are for security around the building. It's not like we're security fenced, obviously. All right, we're sprinklered, right? Good. So those are some of the things. The other part is giving a report, which Julie and Katie did a nice picture of here for me, so I had a good visual aid. Thank you. All right. Good. Questions? We'll save them for the end because we have Beth, and she's really excited to get up here.
Hi, everyone. I gave birth last year, and this is just slightly less scary to me, so bear with me here. We're going to talk about dementia. So this is another licensure required topic, so we pair it with our vulnerable adult. And currently at Andrew Residence, we have 3 people who live here who have a dementia diagnosis. And just dementia is, it's not a specific disease, and I think it's pretty confusing, so I hope by the end of this there's less confusion about what dementia is, but we can ask questions and figure it out together as well. So dementia actually describes a group of symptoms that affect memory, thinking, social abilities, and they have to be severe enough to impact daily functioning. So typical memory loss associated with aging doesn't impact someone's daily functioning. It would not count as dementia. So all of these symptoms fall under the umbrella of dementia and have to do with a decline in cognitive functioning. So there are 4 types of dementia. Alzheimer's disease, which I think is probably the most well-known, Lewy body dementia, vascular dementia, and what is called frontal lobe dementia. So this is the umbrella I was talking about. Symptoms of dementia fall under this umbrella, and Alzheimer's, vascular, Lewy body, and frontal temporal lobe dementia are under that umbrella. And Alzheimer's is the highest rate of dementia. So this little graphic here says 50 to 75% of people with dementia have Alzheimer's, but actually I found other statistics that are closer to 60 to 80%. And then there's vascular dementia next, Lewy body, and frontal temporal lobe, and we'll talk about all of these. So risk factors for dementia are age, of course. So being over the age of 65 increases your risk. A family history, but having a family member who has had dementia doesn't necessarily mean you will get it, but there are genetic components. Someone having Down syndrome by middle age, many people who have Down syndrome develop an early onset of Alzheimer's, and already having mild cognitive impairment increases your risk of having dementia. Early warning signs for dementia include difficulty using complex information, difficulty problem solving, and difficulty performing complex daily tasks. So, these are across the board early warning signs and cognitive signs, but we'll talk more specifically with different types of dementia in a little bit. But of course, memory loss is kind of the hallmark symptom of dementia. Memory loss is usually one of the first things that is noticed by spouses, caregivers, or friends. My stepfather has dementia, and it was actually noticed at work. So he was having trouble completing complex tasks at work, and his coworkers noticed because we all spend so much time with one another and notice things when things are different. So difficulty communicating or finding words, difficulty reasoning or problem solving, difficulty planning and organizing things, and coordinating motor skills, and then of course confusion and disorientation. Behavior and psychosocial symptoms include personality changes, depression, anxiety, poor social boundaries, paranoia, agitation, hallucinations, and sleep disturbances. I think this gets really tricky for us here in this environment because this really mirrors people's mental health picture. So it's really hard to tell if someone's experiencing changes in their cognition or having an increase in anxiety or having some poor social boundaries. It might look just like their mental illness. So one thing that we do here is we complete a mini mental status exam, and those are completed by our wonderful group of social workers here, and every resident over the age of 50 has one. If someone has a dementia diagnosis, it's completed every year so that we can look back. And if you're noticing anyone on your caseload or anyone on your floor is having some cognitive impairments, you can always talk to the social worker, have a team meeting, and a mini mental status exam can be completed. So no one really knows the causes of dementia. Like I said earlier, there's some genetic components, but it has to do with nerve cells in the brain being damaged, but there's over 100 causes, and there needs to be more research. So let's talk about Alzheimer's disease first. In people over 65 years, Alzheimer's is the most common form of dementia. Alzheimer's is what is called a progressive form of dementia, which means over time the symptoms get worse. The symptoms usually develop slowly, and they're noticed by close family or friends, and then they become severe enough and completely overwhelm a person's functioning. I have a quick video.
We often hear about individuals with dementia and Alzheimer's disease. This is usually followed by questions such as, what is the difference? Will it happen when I get older? Don't both diseases just affect memory? By the end of this video, we will learn about both disorders and how different they actually are. First, let's look at dementia. Chances are that someone you know is affected by dementia. 1.1 million Canadians are affected either directly or indirectly by this disorder. Dementia is a term used to describe a wide range of symptoms that show a decline in mental function and ability. This makes day-to-day activities more difficult. Have you ever tried to say something and truly have been at a loss for words? Common symptoms of dementia include difficulty communicating, loss of memory, and a loss of proper judgment. It is quite common for people to contribute their forgetfulness to simply old age. Although aging is a risk factor of dementia, it is by no means a normal part of the aging process. What exactly causes dementia? Dementia occurs when brain cells in certain areas are damaged and not able to communicate with each other. This affects brain function. It's similar to broken telephone, where the message does not get across due to lack of proper communication between people, just like brain cells. The area of your brain that is responsible for your memory is the hippocampus, and cells in this area are typically what is damaged first, causing the problems with memory. Most of this damage is permanent, and the process is gradual, meaning that the disorder worsens in small increments over time. Dementia is considered an umbrella term, with various diseases grouped underneath. The most common disease classified under dementia is Alzheimer's disease. Approximately 44 million people worldwide have been diagnosed with dementia, with Alzheimer's disease making up 60 to 80% of those diagnosed. An individual can have dementia that has no link to Alzheimer's disease at all. Similar to dementia, Alzheimer's disease can cause problems with memory, but it can also cause issues with thinking and behavior. In the brains of those diagnosed with Alzheimer's disease, there are protein buildups called tangles and plaques that are found in and between the cells. These disrupt cell-to-cell communication in certain brain regions, causing problems in memory and language. Although both dementia and Alzheimer's disease may cause memory loss in individuals, both disorders are vastly different in their cause and definition. Understanding the difference between the two is important to understand treatment methods, to have a better understanding of what a person may be going through and how to help. Please visit the following website for more information: www.alzheimer.ca.
We're close enough to Canada, right? It's fine. Oh, sorry, everyone. Thanks for that one. Okay, so I hope that clears things up a bit with Alzheimer's is a form of dementia, just kind of one of the confusing parts. And all these people, very well-known people, have been diagnosed and are deceased because of Alzheimer's disease. So we have Ronald Reagan, Rosa Parks, Norman Rockwell, that's Gene Wilder as Willy Wonka, and Rita Hayworth, whose real name is Margarita. Actually, fun fact. And I read something that Norman Rockwell paintings are actually frequently used in therapies with people with dementia because, the pictures elicit like a nice response from people, and it helps with reminiscing about the past. So kind of interesting that his work can be used to help. All right, another form of dementia is Lewy body dementia, and Lewy bodies are abnormal clumps of protein that are found in the brains of people with this type of dementia. So they're found in people who have Alzheimer's disease as well as Parkinson's disease, which I'll talk about that right here. So Lewy body dementia, people who are living with this really have trouble with thinking and moving, and there's two types. So dementia with Lewy bodies, cognitive symptoms appear first, and then there's also Parkinson's disease dementia, where Lewy bodies are found in the brain, and this affects movement first. So you get diagnosed with Parkinson's disease generally, and then if someone has some mood symptoms and memory components, they might have a diagnosis of Parkinson's disease. But it's extremely hard to diagnose, and a lot of times is diagnosed through an autopsy. So Lewy body dementia, the symptoms include slow, rigid movements, hallucinations and delusions, fluctuating cognition, and sleep disturbances with vivid dreams. And again, we're hitting on where this is challenging when you're working with people who have mental illness, because it, again, mirrors a lot of the symptoms that people who we work with have. So Robin Williams. Robin Williams was diagnosed with Parkinson's disease a few months before he died. And then after he died, an autopsy showed that he had a very progressive form of Lewy body dementia. And I have an article that was in the back. Some people might have grabbed it, but it was written by his wife. And if you need a copy, let me know. It's a really nice firsthand family-written article about living with someone who was suffering from Lewy body dementia, and she writes it specifically for caregivers and people in the field to kind of know what she was going through with her husband before his death. All right, next we will talk about frontal temporal dementia. So frontal temporal dementia is a group of diseases characterized by breakdown of nerve cells in the frontal temporal lobes of the brain. So this type of dementia is extremely sad because it has an early onset between the ages of 45 and 64 years old. As this illustration shows, so your frontal lobe, when it's impacted, it causes a change in personality, behavior, and loss of inhibitions. And then your temporal lobe generally has to do with language and speech. So signs and symptoms: poor judgment, loss of empathy, social inappropriate behavior, lack of inhibitions, repetitive compulsive behavior, frequent abrupt mood changes, speech difficulties, problems with balance and movement, and of course memory loss. And so this type of dementia, you really see the person who you know change. Their personality changes and their behavior changes, and the average life expectancy for someone who has this diagnosis is 10 years. This is John Barry. He was a founding member of the Beastie Boys, and he is someone who passed away at age 52 from frontal lobe dementia. And his father wrote an article for Rolling Stone that you can read, and it talks all about like the personality changes that he saw in his son leading up to his death. All right, and our fourth type of dementia that we're going to talk about is vascular dementia, and this is caused by brain damage from impaired blood flow. So frequently vascular dementia is caused by if someone has a stroke, but it doesn't have to be caused by that. So it has to do with a blocked artery to the brain, and it causes problems with reasoning, planning, judgment, memory, and thought process. The symptoms include disorientation, confusion, impaired memory, difficulty with organization, unsteady gait, and depression is extremely common. And then kind of a specific symptom of vascular dementia is uncontrolled laughing and crying. Margaret Thatcher, who was the Prime Minister of England, had a diagnosis of vascular dementia. And her daughter wrote about when she was in the stages of having vascular dementia after she was Prime Minister, that she, for example, she thought her husband who was deceased was still alive, and she would leave her home and get lost in the community, and she was just a totally different person. And she was known as the Iron Lady. She was really, she really like got things done in England, and suddenly she was just a totally different person because of her dementia. And your risk of having vascular dementia increases if you're a smoker, or if you have diabetes. So prevention of dementia, no one knows, more research needs to be done, but there are some things that can help you, like live an overall healthy lifestyle that could reduce your risk of having dementia. So keeping an active mind, playing like Sudoku and word games, and doing like crossword puzzles, playing cards, staying active and spending time socially with friends and family, being physically active and exercise, not smoking, getting enough vitamin D, because research has suggested that people with low levels of vitamin D are more likely to develop Alzheimer's disease and dementia, which is a bummer for us here in the north, but there's supplements that can help with that. Lowering your blood pressure can be helpful, and maintaining a healthy diet. So let's talk about tips for working with people who have dementia. So my first tip here is set a positive mood and interactions. So your body language communicates a lot, just as much as your words, and you want to set a positive mood and speak slowly. To people who have dementia, you want to create an environment that's inviting, and you might want to, for example, go into the small lounge and maybe close the curtains a bit or turn like bright overhead lights off. You might want to remove distractions or other people from the room. You want to get the person's attention by using their name, turn off like the radio or the TV, make sure you have their attention. And if the person's seated, you want to be seated as well because you want to make eye contact. State your message clearly, use the person's names instead of pronouns. And use simple words, again, speak slowly. Try to keep your voice at an even keel. Ask simple answerable questions. So don't ask open-minded questions or open-ended questions, ask open-minded questions. So yes or no answers are helpful. Speak in a reassuring tone, and when the going gets tough, and if you're working with someone who happens to get agitated, change the subject or the environment. So ask someone if they want to go out for a walk, or even like come down to coffee shop group that's going on down here. Just try to roll with the punches. And an example for how to communicate in like instead of asking open-ended questions, let's say you're trying to help someone pick out an outfit for the day. Instead of saying, what do you want to wear? It's helpful to say, like, do you want to wear your white shirt or your blue shirt? And even more helpful is if you use visuals and show the two different shirts and let someone pick it out that way. Another helpful tip is remembering the good old times. So someone with dementia might have trouble remembering what happened 45 minutes ago, but they might remember something that happened 30 years ago very well. So talk about the past, interests, family, things that happened when they were younger, favorite foods, that type of thing. And of course, evaluate your approach. So we work in teams here. So if you didn't get the response you wanted, evaluate it with your team. Talk about what did work, what didn't work, if you're trying different interventions. Think about the person's level of functioning. Never get in power struggles. Don't argue. And if you're noticing any changes in someone, of course, discuss it with your team as well and share what works. So there is a dementia fact sheet. There's just some more, like 10 signs of dementia, what to do here at Andrew Residence if you notice someone was having signs of dementia, and then strategies to help, kind of what we just reviewed. And that's all I got. You have any more questions? No? All right, we're good. Thank you for coming, and remember to sign in because this is one of those in-services we'll be after you in the next 30 days to see. So remember to sign